Next, cause of megaloblastic anemia. Megaloblastic anemia is either caused by folate deficiency or vitamin B12 deficiency and pernicious anemia due to lack of intrinsic factor. On peripheral smear, we show macrocytes and delayed maturation of erythroblast. Decreased RBC, decreased hematocrit, increased MCV, increased size of the RBC, and hypersegmented neutrophils and increased homocysteine level are the laboratory features in megaloblastic anemia. So iron therapy. If hemoglobin less than 12 gram in women and less than 13 gram in men, it is iron deficiency anemia. If it is more than 10 gram, it is mild anemia. We have to look for CRP. If CRP is normal, we have to give oral iron therapy. If CRP is elevated, with mild anemia, we give IV iron therapy. And hemoglobin less than 10 gram, it is severe anemia, we give IV iron therapy. Oral iron therapy total daily dose is 150 to 200 milligram elemental iron given in 3 to 4 divided doses, each 1 hour before meals. Do not prefer gastric coated tablets, and in case of gastric intolerance, change the route and change the preparation or reduce the dose. Oral iron treatment may require 3 to 6 months to replenish the body stores. Treatment for cobalamin deficiency, parenteral IM 1000 microgram daily for 1 week and weekly for next 4 weeks until hematocrits become normal. Pernicious anemia and malabsorption, monthly cobalamin supplementation, and folate deficiency, folic acid 1 to 5 milligram per day orally for 3 to 4 weeks. So if we classify anemia based on peripheral smear, one is microcytic hypochromic anemias. Cause is iron deficiency, thalassemia, anemia of chronic disease lead poisoning. Another is macrocytic normochromic. Macrocytic anemia causes are megaloblastic anemias. Non-megaloblastic include alcohol, liver disease, myelodysplasia, plastic anemia. Another is normocytic normochromic. Causes include many hemolytic anemia, anemia of chronic disease, renal disease, bone marrow failure due to post chemotherapy, and infiltration by carcinoma. So in this slide, this is nutritional deficiency anemia, where it is showing angular stomatitis and glossitis. This is failure of the palpebral conjunctiva in case of anemia. Next, WBC, first we see the neutrophilia, rise in the neutrophils. Causes include acute inflammation and bacterial infection. When severe, we call it as leukemoid reaction. Clinical features include infections of clinical features like fever, fatigue, or trauma features. So there is increase in the neutrophil level in the peripheral smear. Lymphocytosis, increase in lymphocytes commonly causes are chronic inflammation, viral infection, fungal and TB, and large lymphocytes with more cytoplasm and irregular indented by RBC, also known as virocyte. So reactive atypical lymphocytes. Clinical features include chronic fever and lymphadenopathy. Increase in the lymphocytes in the peripheral smear. Mononucleosis, infectious mononucleosis is viral infection causing rise in the lymphocytes. Features include fever, fatigue, sore throat, and swollen lymph glands. Next is eosinophilia and basophilia. Eosinophilia is more than 5%, basophilia more than 1%. Causes include type 1 allergic reactions and chronic myeloid leukemia and polycythemia vera, and eosinophilia specifically parasitic invasions, rheumatoid arthritis, and lupus erythematosus. Basophilia causes include myxedema, thyroiditis, and type 1 diabetes. Monocytosis, if count is more than 10%, it is monocytosis. And bacterial infections include tuberculosis, syphilis, subacute bacterial endocarditis, and viral infections, protozoal and rickettsial infections, malaria and typhus, and convalescence from acute infection, and hematopoietic disorders like leukemia and myeloma are causes of monocytosis. Next is decrease in the count of neutrophils. Neutropenia, reduction in the granulocytes, decreased production in the bone marrow, or increased destruction due to immune-mediated drugs. When severe, we call it as agranulocytosis. Clinical features include chills, fever, fatigue, and ulcers. Neutropenia, primary is Costman syndrome, and acquired secondary is myelotoxic drugs, phenothiazines, and infections like in mononucleosis, hepatitis, HIV, rubella, TB, and staphylococci, and bone marrow metaplasia, and autoimmune destruction by cytokines and antibodies. Drugs are aminopyrin and propyl thiouracil and penicillin. Leukopenia include WBC count less than 4,000. Pancytopenia causes include bone marrow tumor, aplastic state of bone marrow due to ionizing radiation, and chemotherapy of the tumors, and intoxication with benzene or myelotoxic drugs like NSAIDs and devomycetine. And pancytopenia causes, other causes are B12 deficiency and overactive spleen. Eosinopenia after anaphylactic attacks and severe stress and increased glucocorticoid levels. Lymphopenia causes are primary immunodeficiency and immunosuppressive drugs, and measles, poliomyelitis, and AIDS. Destruction of lymphocytes is common in AIDS. Monocytopenia is not a distinct disorder.